All right. Good morning, everyone. I am talking today about clinical updates in multiple sclerosis. Thank you guys for hopping on. I know it's always early on these Monday mornings. I have no financial disclosures to report. The objectives today are pretty straightforward. I want you guys to be able to describe the updated criteria for the diagnosis of MS and understand kind of the relevance behind all of it. And be able to initiate not just acute care and workup for MS, but also using a little bit thought process about early involvement of additional appropriate specialties too. So I wanted to include this slide. When I'd previously given a talk on MS several years ago, I included some quotes de-identified from my adolescent patients living with MS. This one is a young kid or a young teen rather, who said that I wish people would understand how difficult it can be to move around some days and how much this can change from day to day. And this is a pretty insightful perspective because one of the commonalities I heard through training and beyond are just feelings of being judged by how they appear. Their fatigue, sometimes the labor it takes to walk even a short distance is overlooked. They don't necessarily have a wheelchair or a cane. And so at times, our pediatric patients and kind of from their classmates and co-athletes, they're judged as weak or lazy. And then another one, I'm not different than other people. I can pretty much still do everything all my friends do. I just know that some things will wear me out more sometimes. And it's hard to explain to non-medical people. If I have a really fun day full of activity, I will be worn out the next day and not feel well. And it really is hard to explain to non-medical people. And so this is why leaning on our multidisciplinary care from colleagues is so important. And it's important to involve sometimes heavy communication with the schools. And that especially entails a lot of collaboration with our neuropsychology colleagues. And again, the incredibly dynamic nature and symptoms that can't be seen make it tough for so many of our individuals with MS, especially our teens. So in the United States, there's roughly 1 million individuals who are estimated to have multiple sclerosis. Globally, that approaches about 2.8 million, and I suspect that it's probably a lot more just given, some countries with their lack of access to medical care, lack of access to MRIs, all of that. Up to 5% have their first attack prior to age 18 years. And then this is the leading cause of disability in young adults just after trauma. I always like to include this cascade. We're not going to go into the nitty-gritty of the immunology and neurobiology behind MS because it is very, very complicated, as will be evidenced later by just the sheer number of disease-modifying therapies, the different mechanisms that are being utilized. But it's such a complex interplay, and the pathophysiology can also differ at various stages or within different subtypes of MS. The immunopathology does shift even from going from relapsing remitting MS into our progressive forms of MS. And a big role, if I had to put it simply, a big role has been shown to be played by overproliferation of our T inflammatory or our pro-inflammatory T lymphocytes, so Th1 and Th17, Th1 producing interferon gamma and Th17 cells producing interleukin 17. And eventually, with a complex interplay with macrophages as well as B cells, there's breakdown and crossing of the blood-brain barrier, which then triggers the inflammatory attacks and lesions. In terms of categorization, there continues to be 4 predominant subtypes. So relapsing remitting, so I've underlined that, italicized it. This represents 98% of pediatric onset cases. Then there's also primary progressive, secondary progressive. I've put asterisks and highlighted radiologically isolated syndrome because we'll get into this and how the updated criteria may change the scope for individuals diagnosed with this. And then I put a strike through clinically isolated syndrome. With the 2017 updates to the MS criteria, you're slowly seeing a little bit less of this reported in the literature because these individuals can be diagnosed with MS now. So clinically isolated syndrome, this really represents the first episode of neurologic symptoms, so clinical symptoms caused by demyelination. And again, historically, these individuals were not diagnosed with MS, but this has changed a little bit under the 2017 criteria. Radiologically isolated syndrome. This is when incidental MS lesions are found without any clinical symptoms. This was originally defined by Dr. Darren Okuda. Some of you may still remember him from his time in training in Phoenix. And we'll get into this a little bit more, but there was a landmark French study in 2019 that revealed that in adult patients with RIS, 51% of these patients convert to MS within 10 years. However, the proposed 2024 McDonald criteria, which have not been published yet, will also allow for RIS to qualify earlier as multiple sclerosis. You guys are all familiar with this. Anything neuroimmunology, we love our steroids. So why treat MS relapses and new lesions with steroids? We know that initiating steroids may not change the overall outcome or the overall degree of recovery. However, it can in MOG and NMO. And as you guys know, as we wait for tests to come back, that can take a couple weeks. But in addition, delaying onset of steroids in things like MOG can actually lead to poor recovery. So it is really important to start, especially if we don't know the diagnosis. But even so, while it won't change the degree of recovery, it can improve the rate or the speed to which they attain that recovery, which you can imagine is pretty important in a teenager who needs their vision to be able to get through school and sports. For acute relapses, you want to initiate high-dose corticosteroids up to 30 milligrams per kilogram per day for 3 to 5 days with a max dose of 1,000 milligrams. And then having a lower threshold now to consider a slow oral steroid taper. And this is really due to the benefit that's being seen in MOG-AD. So especially if you're still not 100% certain that you've ruled out MOG antibody disorder, going ahead and utilizing that slow oral steroid taper. This is an outdated slide now, but I wanted to keep it in this talk just because I wanted to highlight one thing on this slide. As you can see, predating the 2000s, development of MS treatments was pretty slow. 1969, we only had ACTH approved for acute relapses. 1993 was when the infamous beta-seron brand name medication came out, and individuals diagnosed with MS were enrolled in a lottery system to get this medication. But 2000 have really represented this robust increase in medications. I put an orange X over Novantrone. It's still on the market. So that's mitoxantrone. It's still on the market, but really you don't see people using it much just because of the incredible side effects with it and the monitoring that goes into it. In red, so in 2016, there was one medication that was approved, daclizumab, which was then shortly after taken off the market due to some pretty significant effects. And then in 2018, I highlighted that because 2018 is when fingolimod, which was previously known under the brand name Gilenya, that's when we received expanded FDA approval for use in kids from 10 to 18 years. This is the full comprehensive list, and by no means we're not going to sit and talk about all of these medications, but now there are 27 medications that are approved for use in the US. And I highlighted Gilenya and Tecenso because those are both different brand name versions of fingolimod. So those do have approval again for use in our pediatric onset patients. Um, and many of these medications are actually biosimilar. So they either have different administration routes or they may have slight molecular differences. And then again, since 2018, we have not achieved FDA approval for any of the other medications for use in our pediatric patients. So much of what we're doing is off-label. So again, greater than 98% of cases in pediatric onset MS are relapsing remitting. 5% of all cases of MS cases start in adolescence. There are some studies that cite up to like 7% or even a little higher. The median age of the first attack is 11 to 13 years, and race and ethnicity seem to be less of a factor for our pediatric patients compared to adult onset MS patients. I just put these two graphics for two very wonderful organizations for our pediatric MS patients. There's the Pediatric MS Alliance, which the president of that organization is actually from Phoenix in Arizona. And then Oscar, the MS Monkey, has been a really supportive group to a lot of my families along the way as well. In pediatric onset MS, so as you guys may know, you may be more familiar with the ratios of female to male ratio in adults, so 2.5 or 3 to 1. In children who are pre-pubertal, so less than 12 years, the ratio is approximately 1 to 1. And in children who are approaching puberty, that ratio starts to approach the 2 to 1 ratio. Pediatric onset MS is more highly inflammatory. So, that's why, for our residents especially, you go to the adult side and on scans for MS, you see these nice ovoid lesions, and then you come back to pediatrics world and you see these larger, more tumefactive appearing lesions, especially in our younger kids. There's a 2 to 3 times increased risk of relapse, and the relapses are more likely to occur within the first 2 to 3 years of diagnosis. And at the time of diagnosis, our pediatric onset patients often have higher lesion burdens as well. There also appears to be a greater degree of axonal involvement, so not just the myelin breakdown, but actually, causing injury to the axon itself, in particular with our prepubertal children. And this has even been noted in postmortem studies of pediatric versus adult onset MS brains. And then we know that there is a greater degree of T cell proliferation as well in pediatric onset MS patients. So in pediatric onset MS versus adult onset MS, what we are understanding is while there are lower disability scores at the onset, and there can be a greater degree of recovery between the relapses. So initially you have this phase of physical disability remaining low. At a younger age than the adult onset individuals, they will reach higher disability scores at a younger age. And cognitive deficits can also be more prevalent in our pediatric onset MS cases. So you can imagine if you develop MS at age 12, the cognitive deficits might actually interfere with your functioning by the time you're in your late 20s or early 30s, especially if, your MS is continuing to progress and you're having relapses. So, and the cognitive deficits can include slowed processing speed, greater attention deficits, cognitive fatigue or brain fog, as well as changes in visual spatial abilities. Risk factors in pediatric onset MS are really relatively similar to adult onset MS. So we know there's this link with low vitamin D level. There can be a link with your latitude, which again goes to your sun exposure and your vitamin D level. Your obesity, especially in pediatric years, exposure to smoke, and remembering that this includes secondhand smoke. And this also includes vaping as well as traditional cigarettes, certain viral exposures, and then genetic influences and estrogens and puberty. In terms of genetics, family and twin studies do support a genetic basis, but there's a very clear overlay of additional triggering environmental factors. So in first degree relatives, the risk of developing MS approaches about 5%. And then in identical twins, if twin A has MS, the risk of developing MS in twin B approaches about 30%. In terms of genetics and family history, I do also ask about family history of other autoimmune disorders since there are links with certain HLA haplotypes. So getting into diagnostic criteria, many of you may be familiar with what we call the McDonald's criteria. I was curious to understand what the criteria were before 2001. So before Dr. McDonald and the panel that he established internationally came up with the McDonald's criteria. So I called this slide vintage criteria. So the very first set of criteria that I could find that were published was called the Schumacher criteria, developed in 1965. And understanding that when that criteria was developed, it was really truly based on kind of clinical history and presentation because they didn't have MRI capability. And I did see that oligoclonal band testing was in existence, surprisingly back then, but it was not yet available in the United States. So there were limitations internationally and nationally with doing that testing. And then in 1983, Dr. Charles Poser, who was born in Belgium and then ultimately immigrated to the US with his family, he published an updated set of criteria. And this criteria came after the advent of the MRI, and it was also post to oligoclonal banding. This was a book I found on Amazon, one of the older books on the diagnosis of multiple sclerosis. And interestingly, this book that I found on Amazon had both Dr. Poser and Dr. McDonald listed as authors. So in 2001, the McDonald criteria was first established. And then since then, the McDonald criteria has undergone pretty major revisions in 2005, 2010, 2017, and then most recently, 2024. So in order to understand the changes to the 2024 criteria, I think it's important to just kind of talk quickly about the 2017 McDonald criteria for those who are not familiar with this. So the 2017 criteria really emphasized kind of more than ever dissemination in space, but also dissemination in time. And this revision through several studies was demonstrated to apply equally to pediatric onset MS as well. So this is a very busy table here that I took from the National MS Society, but takeaways from this graphic. So in individuals specifically with relapsing remitting MS, if they have had 2 or more clinical attacks, that fits with demyelinating attacks. So they already have their dissemination in time that is met. You can then demonstrate dissemination in space with lesions in 2 or more CNS locations. If dissemination in space is met, you can then meet dissemination in time by either an additional clinical attack or on the initial MRI, if you have simultaneous presence of enhancing and non-enhancing lesions, that can demonstrate dissemination in space as well. Dissemination in time as well, because of the differing ages of the lesions. Or you can demonstrate it through new lesions on a follow-up scan. Oligoclonal bands were also added in 2017 to be supportive for dissemination in time. So showing that there's ongoing inflammatory activity going on in the spinal fluid. And again, so the 2024 McDonald criteria really was presented at ECTRIMS, which is the European Committee for Treatment and Research in MS, in 2024. And the goal of it is to include updated objective measures based on our advancements in technology, clinical labs, research, updates in our imaging modalities as well. So why change the criteria? Why even bother with this? And so this is another busy schematic here. Um, but I want you guys to focus on the x-axis is showing kind of the average age in years of onset for things like CIS and primary progressive and secondary progressive disease. The y-axis is the degree of disability. Okay, and then the black dotted line is the clinical threshold line here. So this is the line that you cross with the inflammatory lesion, and ultimately you develop clinical symptoms that correspond with it. The black solid lines around these blue bars that have passed that clinical threshold line, that's indicating, again, physical symptoms or relapsing remitting disease. You have an attack that crosses that line, you have symptoms, you may recover in between, at least to some degree. Over time, that recovery may be less. The first attack that you have that presents with clinical symptoms, that's when we call it, or would have called it, clinically isolated syndrome. Preceding that, we know that there are inflammatory attacks and development of lesions, what are called clinically silent lesions, that leads to this pre-symptomatic disease, or what we now know as radiologically isolated syndrome. And so the goal of the updated criteria is try to make the diagnosis even before clinical symptoms are so apparent, so you prevent ongoing progression. In the background, so this blue dotted line shows the underlying disease progression. So as you have more lesions and more inflammatory activity, there is this additional background progression that eventually leads into secondary progressive disease, especially if we're not controlling the disease and as we're trying to understand the benefits of our disease-modifying therapies more and more as well. The red line depicts axonal loss. So as you get into the more chronic stages of MS and the more inflammation there is, you have a greater degree of axonal loss. And then the solid red line is showing how over time individuals do develop brain atrophy. So in terms of the 2024 McDonald criteria, there is a proposed revision to the dissemination in space. This will be the first time that they would actually include the optic nerve, so optic neuritis, as a potential location for dissemination in space. Historically, we have not included that, and that came down to a number of reasons, which we'll talk about later. But one thing to just kind of take note of is that optic neuritis in MS is usually shorter segment and confined to the optic nerve and tends to be unilateral. If you see an individual, if you see a teenager or a pediatric younger patient coming in with bilateral optic nerve involvement and longer segments of involvement, you want to move things like NMO and MOG higher up on the differential. And if you see radiology commenting on enhancement of the optic nerve sheath, that should also guide you towards putting MOG towards the, higher up on your differential. So additional lesion areas or additional locations that can meet criteria for dissemination in space. So shown by the red arrow here, that would be consistent with a juxtacortical lesion. You guys are probably familiar with the very classic periventricular lesions, so the lesions that are actually abutting up to the ventricle. And on sagittal views, the way that they look, they over time developed that name Dawson's fingers. You can have infratentorial lesions, so involving the cerebellum, and you can have spinal cord lesions as well, meeting criteria for dissemination in space. Just a note about MS spinal cord lesions, they tend to be shorter segment, so you're less likely to see longitudinally extensive lesions or those that span more than 3 spinal cord segments. The lesions tend to be more patchy in terms of their distribution. Terms of optic neuritis. So adding this to the criteria can allow for earlier diagnosis. Optic neuritis is the initial symptom in approximately 20 to 30%. And again, it previously was not included due to difficulties with obtaining certain types of tests and also testing being subject to error. So the three kind of mainstays, in addition to input from our ophthalmology colleagues that we utilize to diagnose optic neuritis, are MRI of the orbits, ocular coherence tomography or OCT testing, and then visual evoked potentials. So when you look at orbital imaging, and diagnosing optic neuritis, studies cite that anywhere from 3 to 10% of cases may be missed on imaging due to movement artifact, even varying interpretations between a skilled neuroradiologist versus if a center has general radiologists reviewing the imaging. And then we know that there's been advent to our imaging techniques, our protocols, and so now we do have improved sensitivity with some of those newer imaging techniques. In terms of ocular coherence tomography, which we'll talk about on the next slides, this can be better for diagnosing clinical optic neuritis. And then visual evoked potentials, I think, they still have a place in the diagnosis of either subclinical optic neuritis or a remote history of it. But they are used, I would say, less than OCT. So OCT testing is more sensitive to retinal changes and better at confirming the diagnosis of clinical optic neuritis. During the acute phases, you may actually see evidence of thickening or increased retinal nerve fiber layer thickness due to the associated edema that can occur. But as the swelling resolves over time, the retinal nerve fiber layers are decreased and can show thinning. Better software for our ophthalmology colleagues now allows for the ability to segment out or separate out each segment of the retinal layer. So, for example, the ganglion cell layer, the inner plexiform layer, and that helps them with the interpretation of OCT testing. Also, faster acquisition times in terms of taking the pictures themselves mean better tolerance from our younger and our more squirmy pediatric patients. I'm just showing this slide very quickly to give you guys an idea of what OCT testing for those who have never ever heard of it. The area that I usually kind of focus on is this RNFL thickness if I were to see the images. So both for the solid line and the dotted line, which represent the right eye and left eye, you want them to be in the green as much as possible. If they are predominantly in the yellow or predominantly in the red, then that indicates thinning. Similarly, if these lines are out of range or above the green area, that can support swelling or a more acute optic neuritis. In terms of diagnostic biomarkers, I think many of us are familiar with oligoclonal bands and sending for that. But the addition or the revision to the 2024 McDonald criteria would include kappa-free light chain from the CSF, but you can also send it off in the serum as a comparison to the CSF. So Mayo has a test for this, which is KCSF. It's not available as an orderable right here. When I tried to search for it in our system, I know you can get kappa and lambda ratios in the urine. And I think there were a couple, maybe serum, you could order it here, but not from the spinal fluid. So just to take you back a little bit. So when I'm talking about kappa-free light chain, that's one of two light chains that make up the overall antibody structure, right? So you have your light chains and then you have your heavy chains that are linked to these light chains. So kappa-free light chain is measuring this free circulating light chain, so kappa and lambda in the spinal fluid. And then obviously when you're checking specifically for kappa, you're extrapolating out which is specifically kappa. So these are proteins to kind of take you back a little bit more. These are proteins that are created from white blood cells, more specifically from plasma cells. And kappa and lambda do vary in their structure, and they're also encoded on different chromosomes. But the reason including kappa-free light chains in the diagnostic criteria is helpful. Number one is if you look at cost, actually oligoclonal banding, surprisingly to me, was more expensive than kappa-free light chains. You can send kappa-free light chains from the CSF only. So you don't need to worry about having a serum comparison at the same point in time. Um, and then it's faster, it's more automated, and it's less subjective than oligoclonal banding can require at times. And so if you guys remember, oligoclonal banding entails kind of gel electrophoresis, and then these bands pop up in both the serum sample and the CSF, and then someone has to sit there, look at it, count it, compare it. And just like we sometimes struggle to see if our COVID tests are truly showing a faint positive, sometimes that can occur with oligoclonal band counts as well. The other addition is adding in some imaging biomarkers to the criteria, in particular, what are known as paramagnetic rim lesions and the central vein sign. So paramagnetic rim lesions, these are chronically active inflamed lesions or smoldering lesions. They slowly expand with time. And really what we know is that there's this iron accumulation in the macrophages and microglia at the lesion periphery. And so the periphery of these older lesions can appear hypo-intense on SWI imaging. And paramagnetic rim lesions can be a predictive marker for disability progression. So on this image here, hopefully you guys can see it, but the top three pictures. So what this is showing is a chronic lesion. It's been there a while, but it continues to smolder, have active inflammation, as depicted by the rim that has ongoing active inflammation. And the way that we're able to discern that again is, so on FLAIR, you see this hyper intense rim in these two lesions marked by the red boxes. But then on SWI imaging, you see the hypo-intense rim. The bottom three pictures show actually a more acute lesion. So you don't see the periphery being involved in terms of the active demyelination, but rather the active demyelination is diffuse. But this still meets criteria for a paramagnetic rim lesion as well, because on SWI, again, you see associated hypodensity. In terms of the central vein sign, so 92% of MS lesions have what's called a central vein sign. So again, as we talked about the breakdown of the blood-brain barrier, as those inflammatory cells cross that blood-brain barrier and break down that blood-brain barrier, you have this area of perivenular demyelination that's occurring. Lesions with central vein sign are much more prevalent than PRL. So, the proposed criteria would, they're saying that you need to have at least 6 lesions with a central vein sign. And then having a central vein sign has demonstrated to have more specificity for multiple sclerosis, even in individuals who have radiologically isolated syndrome. So you can see the central vein sign on a few different sequences, including, again, the SWI sequence. And it's really apparent as a black vein going through the center of a T2 lesion. And so again, this vein crosses through the entirety of the lesion, which is in pink. And if you look at the axial cuts here, especially the one in C, you can see it very clearly. There is this thin line that is going through this lesion there. And then individuals with RIS under the proposed 2024 McDonald criteria could meet criteria. for multiple sclerosis, whereas they previously it was tougher to try to validate starting treatment, especially in higher risk individuals. So again, this is the earliest detectable asymptomatic phase in the spectrum of multiple sclerosis. And individuals with RIS are found to have this, due to imaging being done for other reasons. So something came up in migraine history that prompted us to get imaging, or imaging is done because they came in as a trauma, things like that. And 90 to 95% of individuals with RIS meet the count criteria for CVS lesions as well, which in adults with RIS, the studies have shown that 33% will develop a clinical attack within 5 years of their initial scan, and greater than 50% will convert to a diagnosis of MS within 10 years. In pediatrics, actually, some updated studies have shown that 42% of pediatric cases with RIS will meet criteria for MS within 2 years. And this graph is taken from the largest cohort in, I think it was done through France. It was about 450 patients with RIS, and that was the largest cohort of RIS patients studied to date. So when do white matter lesions qualify as radiologically isolated syndrome? So this was spelled out again by Dr. Okuda and his colleagues, but really it's an MRI with incidental white matter lesions demonstrating characteristics that are highly suggestive of demyelinating disease. So you jump to number 3 under that bullet point. It's not anomalies that are consistent with microvascular or those non-specific subcortical lesions that we often will see, especially in some of our older teens and adults. And it has to involve the classic MS locations for dissemination in space. So periventricular, juxtacortical, infratentorial, and spinal cord regions. And again, this is easier said in adult patients, but they are ovoid and well-circumscribed lesions and homogeneous with measuring greater than 3 millimeters squared. And then they have additional criteria that they can meet. So if their index MRI, their initial MRI meets at least 3 or 4 of the 4 dissemination in space criteria, then you can diagnose them with RIS. But if you don't meet all those locations or have all those locations in terms of the lesions that you're seeing, then you can justify it by elevated oligoclonal bands, spinal cord lesion, which was not previously on the McDonald criteria predating 2017. And then exclusion criteria are listed here as well. So that was really the, kind of the big updates, the pertinent updates to be aware of that are potentially coming down the pipeline with the updated criteria. I think a lot of people will ask, how do you choose a DMT? And this has been under so much debate that there are 2 big studies that I wanted to bring to your attention. If you go back just even 5 to 10 years, there was more of a mindset of escalating therapy with many MS specialists of starting with a lower efficacy medication and then increasing to a newer, higher efficacy medication if needed. But many issues along the way have kind of made it more difficult to start the higher efficacy medications up front, especially in those who believe that starting with a higher efficacy medication is better in the long term for the patient. And that goes back to that slide where I was showing you the background secondary progression that's happening even preclinically before an individual develops clinical symptoms. So many issues have favored the escalation therapy. So unclear long-term side effects of higher efficacy medications, insurance and issues with access to the newer medications. But I always like to say time is brain. We use that more with stroke and vascular neurology and the timing of TPA, right? And stroke recognition. But again, when you think about that schematic, despite it being over a longer period of time, Time is brain. And when you talk about the degree of disability and that MS is the second leading cause of disability, just second to trauma, then it's important to better extrapolate if we should be starting with the higher efficacy medications. So one study that is underway is called the Deliver MS trial. This is a 3-year prospective study in both the US and the UK with an additional extension arm to follow disability scores up to 4 to 6 years after individuals started the study. Their initial goal was to get 400 participants, and they actually enrolled 800 participants. The aims are to determine whether starting on a highly effective treatment is more effective than the escalation approach in slowing brain volume loss over 36 months. It will also assess which approach is more effective at improving patient-reported outcomes and clinical measures, as well as the safety and tolerability of each approach. And so the medications that are being looked at are alemtuzumab, which you guys may know as Lemtrada, rituximab, ocrelizumab, and natalizumab, which is Tysabri. In the second arm, so the extension, it also includes ofatumumab and another medication, which is ublituximab. The Treat MS trial, the primary completion is actually supposed to be upcoming, I believe, in August 2026, and adult BNI is listed as a study site for this. So this is traditional versus early aggressive therapy for multiple sclerosis. I believe this is in the US only, and their goal is to try to get 900 participants. Aims are to evaluate both jointly and independently amongst individuals who are at higher risk versus lower risk for disability accumulation, whether early aggressive therapy versus starting a more traditional first line therapy influences the intermediate risk of disability. It's also aiming to look at if patients who are initially deemed at lower risk for disability and they start on first line MS therapies, but then experience breakthrough disease, in those who switch to a higher efficacy medication versus a new first line therapy, if there's any different in their intermediate term risk of disability. So I'm excited for there to be some published data on these studies because they have been in the talks and discussions for a very long time. And I think what slowed down probably participation and gathering data was probably in part due to the pandemic. And then just a quick word on some of our new disease-modifying therapies. So something that is kind of on the pipeline here are BTK inhibitors. Some of you may be more familiar with these or heard of them through the oncology world. But these are medications that act on Bruton's tyrosine kinase. And these inhibitors essentially inhibit the intracellular signals that regulate the creation, growth, and movement of B cells and microglia within the central nervous system. It's believed that there's better penetration of the blood-brain barrier with these medications, which is, again, it has a key role in multiple sclerosis. And then the medications that are in the pipeline for MS, so fenebrutinib, remibrutinib, and tolebrutinib, have been modified. And so the hope is for less side effects and adverse reactions compared to those used by our oncology colleagues. So some of the adverse reactions that are reported, for example, in individuals with CLL include things, pretty significant things like cardiac arrhythmias, development of significant hypertension, bleeding, and infections. By fenebrutinib, I wrote down that it's reversible. The other two are considered irreversible BTK inhibitors. So reversible inhibitors may not provide as good of long-term protection, but irreversible BTK inhibitors have better potency and may offer longer-term protection against the, longer inflammatory risks with multiple sclerosis. However, the irreversible BTK inhibitors may lead to increased drug resistance with time. So fenebrutinib I know is in phase 3 comparative studies with a medication called teriflunomide for relapsing remitting MS, but they're also doing a comparison with ocrelizumab to look at its benefit in use for adults with primary progressive MS. And then tolebrutinib, unfortunately, is not showing a significant annualized relapse rate reduction compared to teriflunomide, one of our other DMTs, but it is showing possibility of improved EDSS scores further out. And then I always try to stress that multiple sclerosis and the diagnosis is not just about the neurologists. Having MS doesn't just mean you see a neurologist and that's it. So some things that to consider and just think about. So right now we're trying to work on updating our algorithms. So not forgetting to think about genetic, metabolic, mitochondrial disorders, things that would entail the help from our geneticists, systemic mimickers that might involve our rheumatologists, right? Infections that might involve more support from our ID teams. And then I do want to make a word that if you're sending the demyelinating panel, that does include MOG and aquaporin 4. That gets sent to Mayo, and it includes both those antibodies. So you don't have to also order aquaporin 4 separately. And just being aware that this panel should be drawn from the serum prior to steroid initiation. And again, we're not talking about MOG, but the reason for that is that if you send off MOG antibody 2 or 3 days after starting steroids, that may be enough for the steroids to actually take effect and significantly reduce your MOG antibody levels. So for patients who seem to meet criteria for MS, our inpatient teams, some things to consider are pre-screening labs while the patient is in the hospital for possible disease-modifying therapies that we might be considering. This is just a time saver because by the time they see us outpatient, we want to start that talk of what medications they're even a safe candidate for. So CBC and CMP. They're antibody titers to the chickenpox vaccine. That's helpful in fingolimod. For our anti-CD20 agents, we want to make sure that there's no history of an active hepatitis B infection or also making sure that our teens are vaccinated against it. So sending off their Hep B levels. Don't order the hepatitis panel. I think that's been happening, but that's really to rule out an acute hepatitis and screens for active hepatitis A, B, and C. Checking their baseline immunoglobulins can be helpful for us in the long term for those that we might put on an anti-CD20 medication. And then I wanted to also use this moment to clarify the JC virus antibody. When we request sending off JC virus, unless we are concerned that they are actively sick and having complications due to JC virus, do not send the JC virus PCR. In order to find the JC virus antibody and us obtain those titer levels, with the Easter eggs that SCM brings about, it's helpful to either just type in the word stratify, or we tested this out last week with the inpatient team. If you type %JCV, it'll pull up all tests that have JC virus in it, and that includes the stratify test. And then sending off quantiferon TB and Coxi, because remember, we are altering their immune system with the medications that we're starting, and we live in Arizona. So testing a quantiferon TB and Coxi can be helpful to make sure that, again, we're just being safe and cautious with the medications that we plan to start long term. And then vitamin D. I cannot stress this enough, but checking vitamin D levels and supplementing if they're low because of that link, again, with multiple sclerosis if they are vitamin D deficient. And there's been just enough research over the years to support that vitamin D supplementation and normalizing their vitamin D levels can be helpful in reduction of inflammatory activity. And then it takes a village. So this is a whole list of people that may be involved with pediatric onset MS individuals. So parents and siblings. I do want to mention studies have demonstrated pretty significant rates of depression in our parents of children with pediatric onset MS. Obviously, neurology is involved, but really enlisting the help and filling in their primary care provider. Neuropsychology is incredibly helpful. Psychology, psychiatry, PT, OT, speech. Again, we sometimes have close communication with the school, working with accommodations in terms of a 504B, sometimes even an IEP is needed. Considering accommodations or exceptions for participation in PE and other extracurriculars. If they're having GI or urinary symptoms, enlisting the help of the urology team or gastroenterology, ophthalmology, and then dermatology is also often utilized. From an inpatient team standpoint, some outpatient visits to consider initiating from the get-go is neuropsychology. We'll talk about this more, and we're working with Dr. Whitaker in neuropsychology, but really getting all demyelinating and autoimmune encephalitis patients, irrespective of their recovery, is so important. Because even if they've made a full recovery, it's good to have a baseline. And then if things change in 2 or 3 years down the road, we have a baseline test to compare to. Ophthalmology, it can be helpful to refer our demyelinating patients to, even if there's no evidence of optic neuritis on history or exam. Getting baseline vision testing and baseline OCT evaluations, I cannot stress to you guys, but those can be incredibly helpful. So again, if something changes, we have a baseline to compare to. But sometimes we may need baseline testing for certain medications as well. In particular, fingolimod, if they're a good candidate or a reasonable candidate for that, just because fingolimod can cause macular edema. And just another word, kind of going back to neuropsychology, greater cognitive deficits can be noted in about a third of children with pediatric onset MS. And at least 60% will have some degree of cognitive deficit, with 35% being at least moderately impaired. And that may be in part due to the increased rates of relapse in childhood, the accruing volume loss that's happening in the background, and damage to the underlying gray matter. But if we don't involve neuropsychology and don't stress that importance, I mean, think about how this can impact their life in all domains down the road, their family life currently, if they decide to have children and have their own family down the road. Need for disability benefits as they transition, out of high school, if they decide to go straight into the workforce or college, whatever. All of that is so important to think about. So in summary, there are 2024 revisions that have been proposed to the McDonald criteria, which will hopefully allow for better clarification of who meets MS criteria. We may have improved testing and see better turnaround time with more utilization of kappa-free light chain testing. We may be able to better stratify risk and better clarify, especially in our pediatric patients, who is meeting MS criteria by work with our radiology colleagues. And the 2024 criteria may also allow for more rapid diagnosis and treatment initiation, especially in cases of radiologically isolated syndromes. As I mentioned on one of the earlier DMT slides, a lot of medications are biosimilars. We know some good targets, but some of the newer mechanisms are being looked at for MS, in particular BTK inhibitors. And then again, stressing the early involvement of neuropsychology and ophthalmology. And then just a special thanks to Dr. Mike Robers. He shared a couple of his slides in regards to the updated criteria for the purposes of this talk today. And then, please feel free to email me, text me if you have my number, if you'd like the resource slide, or if you have other questions. Are there any questions? I'm going to stop screen sharing.
That was excellent, Harlori. Very, very appreciative of you.
Thank
And
you.
having this in a resource slide, I think would be very, very good. And having had patients in the hospital recently trying to figure out what things to order in preparation, all that, I think would be very helpful. So I appreciate that.
Yeah, yeah. And again, Dr. Angapan, Dr. Kalon, and myself, we met recently. We're going to start that process of really building out some more kind of clear guidelines, updated guidelines. So I'm really hoping this 2024 criteria will actually be published because I think that will also, um, help with some updated conversations with our radiology colleagues and all of that in terms of what we're looking for and the information that we need.
Well, thank you so much for the talk. As a neurosurgeon, this is about as far from neurosurgery as you possibly could be. But to your point at the very, very end, it impacts us all. And even us as neurosurgeons, we occasionally will see things that are called out as lesions on
Yep.
brain MR imaging or spine MR imaging that end up falling in your category. So I appreciate the update. Thank you so much.
Yeah. Yeah, absolutely. And you're correct, Dr. Hoffman. It's not uncommon for, imaging to be done for some other reason. They come to you, I don't know, just pulling something here, but they come to you, family really wants imaging to evaluate for possible Chiari malformation. You get it, and then they have these random spots. And so certainly if you guys have any questions, you're welcome to reach out to any of us in neurology, but I'm always happy to talk things through, take a look, meet the family, all of that.
Thank you, doctor. So for the slides that you
Yes.
just kindly offered, shall we email like the our rep or you
S- s-
directly or the department?
Oh, yes, sorry. I was not sure how many people outside of our, institution log on for this. I can certainly make sure that my email is sent out. I don't know if Christina can maybe get it out, but it's just H Bains, Bains at phoenixchildrens.com. And I can maybe type it in the chat here too. There.
Thank you so much.
Yep.
Have a great week.
Yep. Thank
Bye.
you.
Thank you, Dr. Bains.
Just making sure no other questions. Okay.
Yep.
All right. Thank you.